Hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. Today we'll be discussing women's health with Dr. Kishore Lakshman. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit Bay Coast Bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are always greatly appreciated. So first of all, before we get into this, and there's so much interesting stuff we're going to talk about today. We're going to talk about women's health, but particularly, it sounds like hormone replacement and sexual health in women, correct?
Yes.
So tell us a little bit, in the audience in particular, about yourself and your background and how you got into this and what your interest is.
Yes, absolutely. So I'm Kishore Lakshman. I'm an endocrinologist working here at Primacare. This is my third time coming here to you guys, so I feel very privileged. So thank you for the invitation. We covered men's health first, and then we covered transgender. And today I'm particularly excited about women's health because it's less talked about, underrepresented, under-researched.
Absolutely.
And there are a lot of myths, especially regarding hormone replacement therapy in menopausal women and women's sexual health.
Yeah, I'm really interested in the hormone therapy aspect because that's changed so much over the years.
Absolutely. And there's so much misinformation, and I'm hoping I can debunk a lot of those so women feel, empowered to talk about it more.
Why is it less represented?
That is so if I were to get into the details of that, I will in a second, but going back to, I know you had also asked me how I got into this space. Before I forget that train of thought, I will come back. Research, I also call myself a clinical andrologist because of my interest in androgen hormones, especially testosterone. So that passion originated for me in the very early years of my training in endocrinology at Boston University.
Okay.
A lot of the clinical exposure that I had, as well as clinical research, was very tied into testosterone and the mechanisms of what it does and how it does in both men and women. So after, going knee-deep into research and getting a lot of knowledge from that, I had the opportunities to apply that in clinical practice. So men's health, treating sexual dysfunction in men, low testosterone states, is kind of where things originated for me. So I brought that to the community, and I'm proud to say we have a pretty well-oiled machine as far as men seeking hormone replacement. We have very good protocols in place. Thank you for the support of the medical community, including yourself. And I think I realized as I went down that path, it was very organic for me to go into the women's health space because the guys that I treated would come back to me and say, hey, listen, we feel pretty good at this point, but our partners need to be optimized. What can you help them out?
Right.
And that's how I organically kind of went into the space, and I was doing that. And I learned it. To this day, I learned so much from my patients, as much as I learned from reading articles and textbooks. So that was a great space to get into. And now where I feel I can treat the couple as a unit, talk to both of them, see what needs to be done, and get them to a good place about sexual health in particular, which there is so much stigma around. So destigmatize that, give them a warm and welcoming space to talk about their health. And because sexual health is a couple's problem, it's not an individual's problem. So it's nice, and I feel really honored to be able to offer both that help. If one person is suffering, the other person likely is also. And going back to your question about why there is so much misinformation, so I have to track back a few decades. So back in, say, the 1990s into the 2000s, hormone replacement therapy was mainstay for menopausal women. That's what we gave. That's what we did. It was a knee-jerk reflex. Somebody is going through menopause. You replace them with hormones. And we have a wealth of data in that period showing how safe hormone replacement therapy
I
is
recall
for
those
women.
days. And then it all changed.
Exactly. So not only in improving their quality of life and their menopausal symptoms, but also deeper things like primary prevention of cardiovascular or
Correct.
disease, and prevention of osteoporosis, maintaining bone health,
Right.
perhaps reducing the risk of breast cancer. So these were some of the valuable goals to also achieve in addition to relieving their symptoms and improving their quality of life.
Right.
And then the hormone ship sank in 2002.
Right.
One of the largest studies to this date in the United States, called the Women's Health Initiative, which was sponsored by the National Institutes of Health, conducted a study. Their goal was to answer two questions. Is it truly helpful in preventing heart disease in women that take hormone therapy? And number two, what does it do for breast cancer risk? In 2002, they found some preliminary evidence that there is an increased risk of heart attack in these patients taking HRT. Also, it may increase the risk of breast cancer. So very prematurely, they held a press conference in Washington, D.C. It was dramatic, sensational news, right? And negative news is always sensational. They announced that, and overnight, just like that,
It was like a switch turned off.
switch turned off, exactly. So hormone replacement therapy abruptly came to a screeching halt. Nobody wanted to take it. People that were on it. So this damaged both the society and the medical community. Patients didn't want to take it. They had this fear of life put into their head.
Exactly.
And the medical community said, back off, I'm not doing this completely. What happened later or after is little known to the society, to women, and also to the medical community. So what happened later? Let me talk about two basic flaws that is often has to be addressed when we talk about what went wrong with these findings of the Women's Health Initiative. So two big categories. There's many, but for the sake of simplifying things. One, the women that were in the study were older women. The average age was about 63, 64. Right. Much older women. So this is a big contrast from a woman that is entering into the menopausal transition in her mid-40s or late 40s, early 50s. Sharp contrast. Number two, the hormones that they gave were different hormones. So they gave Premarin, which is from a pregnant mare. It's urine, hence called Premarin. So that's considered that's not bioidentical. So it only has some similarities to the estrogen that the human ovaries make. It has a mix of other hormones too, a few others. In other words, the estrogenic exposure that Premarin gives to the human body is wide because it has several types of estrogen.
It's not bioidentical.
It is not bioidentical.
And that's a key
exactly
part.
It is exactly
The issue.
And then the second part is the progesterone that they used was synthetic progesterone. Again, not bioidentical, synthetic progesterone. So with these, if you go back to the age of the women, the average age being about 64, they have been in menopause for way over 10 years. So their bodies have taken a hit from being hormone depleted for so many years. And as a result, their risk profile is very different from a younger woman in the 40s or early 50s going through menopause. So that was one flaw. Therefore, it was not surprising that they have a baseline higher risk of getting heart disease as such. So it wasn't surprising that they found this association. Same with the risk of breast cancer. As women get older, and especially after they've been hormone depleted for so many years, they had a higher risk of breast cancer. And something has to be said about that risk of breast cancer too. It was over-exaggerated. There's different risks when we interpret statistics, and that risk was grossly misinterpreted. The second part is hormones. So these hormones that those women got are very different from bioidentical hormones that are widely prescribed now. So as a result, the Women's Health Initiative overgeneralized. They concluded that all women are made the same, all hormones are made the same. that is not true. And they also particularly excluded postmenopausal women who were symptomatic, had hot flushes and other symptoms. That again is insane. How would you do that? So therefore, they didn't have a lot of positive things to report. If they had included women that were symptomatic and you administered quality of life questionnaires before and after, you would also have good things to talk about. But they undermined the good that came out of it, such as quality of life scores, which we didn't have the data. Here,
so it was a very biased.
It was a biased study. Right. So now that we are, 20 plus years from now, over the years, the Women's Health Initiative has retracted a lot of its findings. So much that now some of the sub-analysis showed that there were two arms in the Women's Health Initiative, women that got estrogen only. These are the women that did not have a uterus. It had been removed for various reasons. The others that got estrogen and progesterone for protection of the uterus lining. So they concluded, can you believe the paradox? They concluded a few years later that in the estrogen alone arm, estrogen replacement reduced the risk of heart attacks. And number two, that progesterone and the other concerns that also came up were risks of blood clots and strokes. They concluded that it does not increase the risk of blood clots and strokes, and it improved or it lowered your risk of getting a heart attack. So complete opposite.
So many went without a needed therapy.
Yes. And then they also talked about the fact that combined therapy did not increase the risk of breast cancer.
Okay.
If so, that risk may be coming from the synthetic progesterone that they used. So that we understand now. The risk is probably mediated by synthetic progesterone, which we don't use anymore, and it's a very small risk. But estrogen gave you so many positive things.
It's kind of similar to the whole birth control story from years ago.
Yeah.
You know, how women would have, they might have deep venous thrombosis, pulmonary embolism, et cetera, in these events. But ultimately, the hormones that they were on, one were very potent, high potency.
Correct.
They were at doses we don't use now.
Okay.
And
exactly,
it is somewhat of a similar story.
Yeah,
and
it's a parallel to
it's parallel at least, but the damage was unfortunately done with that study, and it was very public, and it's taken many years to turn the ship around.
You're still doing it, and these positive findings did not get publicity. They did not hold a press conference.
That's the way it always is.
So yeah, exactly.
They never retract when they put a retraction in the paper. No one reads it. It's always
So
big article.
Yeah. So what has happened in the last 2 decades, right? After this nuclear explosion happened for hormones.
Right.
I should say, as such, hormones, there's a sense of shame around hormones for women, which I'm understanding now from meeting so many patients, evaluating them, and also talking to my women in my family. They say this stigma. I think in general, there's a stigma around sexual health, and then there's a stigma around women's hormone. There's almost a sense of shame from birth to later. If it's you're going through puberty, it's like, I think that might be that, she probably is getting through puberty, so you blame everything on, it must be her hormones.
Right.
And once you get into puberty, it must be that time of the month. So you go through that and you rationalize things or look at it from that angle.
I never thought about it. It's very fascinating.
And pregnancy is a whole other thing, right? It's a chronic hormone problem.
Right.
She's a beacon of hormones. Okay, that's hormones. And then there's postpartum. There's a hormone drastic shift. So again,
hormones get blamed for
it must be her hormones. Yeah.
It's
and
interesting.
Then when they're going through menopause, yet again, it must be her hormones. So there's a sense of shame associated with it almost for women. And that's what I hear, which is why a lot of women tear up when they're talking to me about this or being given a platform to actually talk about their hormones. It is...
They don't feel comfortable doing it because as a society we have...
Exactly.
We blamed everything on hormones, really, in some ways.
And like men's health is so well advertised and it's out there and it's mainstream.
All my male patients want testosterone.
Yeah.
Exactly.
They all want.
Whether it's low or not, they want testosterone.
Yeah. And do I ever say the guy's grumpy, it must be his testosterone? We never say that, right? No. But for women, it's
kind of like hidden a little.
Culturally too, right? Women just think, it's menopause, we just got to go through it. Moms don't talk enough about it to their daughters. Everything is just
Interesting.
It's like a touchy subject.
I never thought about that aspect of it, societal aspect,
Yeah.
how we have addressed these
exactly.
issues, but
So
it's an important piece.
women
The
became
commercials that are out even today, it's all about men. You know, it's like you don't see the same amount about women.
You're right.
Yeah.
You see testosterone ads everywhere.
Yes.
And, as for erectile dysfunction,
Exactly.
et cetera. But you're right. You don't see I don't think you see much out there at all for women's sexual health or hormone replacement or whatnot.
exactly.
So true. I didn't think about that, but it's very revealing.
Yeah.
Same thing goes with research, education, platforms, lobbyists, to promote that. So what happened, the already sort of, the stigma around it for women in general got worse. So they said, okay, we're not talking about it. Just to give you some statistics, 80% of women entering the menopausal transition experience symptoms. 80%, which hot flashes is like the hallmark. Only about, before this the Women's Health Initiative crisis happened, only about 25 to 30% were seeking help for going to their doctors for hormone.
Because they were taught this is part of the natural aspect of life, and that's what happens.
Just don't say anything, move on.
Yeah.
And
Which is unfortunate.
and that dropped to 2 to 3%. So now only about 2 to 3% of menopausal women actually seek help for menopausal symptoms.
Wow.
The prescriptions for HRT fell by about 80% after the Women's Health Initiative. Then when you look at the medical community, that dropped significantly. Doctors that were prescribing, only about 25 to 30% of doctors were actually prescribing. Even worse, in the last decades that have come, new graduates in medicine, family practice, obstetricians, they do not get trained sufficiently in menopausal hormonal therapy. It might be like a chapter in their residency. And I have first-hand information. A family friend recently graduated from an OBGYN residency program. She's taken on a big girl job in a couple of months. And I asked how much HRT was taught. She paused for a minute and she said, nothing, barely anything, she said. The only exposure was when she was preparing to take her boards and she was obliged to cover that chapter in her book. So do you see the damage that has caused even to the medical community, so much that there's so much inertia in the community also to treat or talk about it or even bring it up during a normal conversation?
There's a lot of physicians that still believe that everything that was put out there 20 years ago or more now, right, is true.
And
interesting.
Yes, so there's that. So, and then there's who owns this space, right? Do OBs own the space? Do internists, family practice doctors own the space? Do endocrinologists own the space? So everybody is blissfully assuming the other specialty does, and there's fewer OBs than, I think that there was some statistic that to every OB there are 10 or I don't know, internists, family practice, like the ratio is huge. So I think it has to be a shared responsibility in the medical community to at least talk about it, thing, and then I'm happy to see them and treat them, but more conversation. But again, when I say shared responsibility, shared between the medical community and patients, women should also.
Isn't it amazing how appreciative patients are when you do talk about any aspect of their things that they've been suffering in silence with?
Yes.
And sexual health is often one of those issues. It's amazing. It really is.
And too, like as a woman, like when I go to my primary care physician, like there's other issues I'm targeting like maybe 3 issues that I want to go in, and it's like all the other stuff. It's like you don't think about it, or you don't have time for this unless you're experiencing a really
It always gets put on the back burner in primary care because there's so many other things that we need to discuss. So, you're looking at talking about the diabetes and the hypertension and the things that, are important, but this is important too.
Yeah.
But where do you find the time?
Well, yeah. And in my mind, even as a nurse, I'm like, I have to prioritize. I know I have 15 minutes with you. I know if it was important, you would stay more than that.
I think 16 or 17.
Yeah. When you go to your OBGYN, what are you going for? You're like mammogram and it's all like tick the boxes.
Yeah.
And it's like you don't have these conversations.
But these are conversations you can't really do in a 15-minute visit where you're
No, that's
or then depending on who, like sometimes you have the rotation, you might have this doctor at a certain time and then you have the NP or whatever.
Right.
And everyone, like there's nothing concrete. Like you might have all different ideas and then you're like, well, forget it. I'll just wait.
And then how do you bring it up, right? So that's the way I think that the space that we provide, they know why they're here. I know why they're here. So there's no small talk. We get right into it. And obviously maintain some levity around it. We're just having a good time. We talk about it. That's what we do in our offices.
Because I can imagine this conversation, right? The husband's like, hey, honey, we're going to go see this doctor, come on with me. And then they're both sitting there, or they might, both really want to go see you. And it's like, how do you start?
So today, I just remembered, this is fresh in my mind from this morning, a new consult. She had come in, she's in her 60s, for sexual dysfunctions. She'd heard of me and she said, wow, this is amazing that I can talk to you about it. And we had a lengthy conversation. At the end, she teared up a little and she said, just talking to you, I feel lighter and I feel so much better. Whether you treat me or not.
That's wonderful.
I'm going out of here. I needed lab, so I said, come back. She said, I feel good. Just talking about it. Thank you for listening. So I think it has a profound impact.
Yeah.
Hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast Studio in Fall River, Mass. Today we'll be discussing Inspire with Dr. Ameer Shah. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Also, Duncan Hearing Healthcare. Hearing healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform and by following us on Facebook and Instagram. Also, please remember to leave a review. 5-star reviews are greatly appreciated. So now we are going to turn over to Dr. Ameer Shah, and we can start by, can you tell us a little bit about yourself?
Sure. Well, I first want to thank you so much for having me on today. As you said, my name's Ameer Shah. I'm a otolaryngologist based out of the Taunton area. My practice is ENT specialist. We have a few offices in Brockton, Taunton, Plainville, and Norwood. I grew up in the Boston area. I grew up on the South Shore in Braintree, and I was excited to practice kind of where I grew up. I did most of my training in medical school in Boston at Tufts, which was not too far away, but kind of nice to come back in this area and take care of the community that I grew up in. My clinical interests are kind of broad in the field of otolaryngology, or as people call it, ENT, ear, nose, and throat.
Yes.
I practice kind of the broad range in terms of adult and pediatric care. But my kind of clinical focus and interests have been in head and neck cancer surgery as well as sleep apnea surgery, which kind of lends itself to today's discussion about the Inspire implant.
So now we're going to be talking about sleep apnea, obstructive sleep apnea. Can you kind of give our audience an operative definition, if you will, just like what that is?
So, a large portion of the population snores. Snoring does not necessarily mean sleep apnea. Sleep apnea really means that you stop breathing for short periods of time during your sleep. Kind of from a medical definition standpoint, we have to correlate a duration of that pause in breathing with a drop in your oxygen levels that are measurable in your blood. And that is what's defined as an apnea. And so people can have varying severities of sleep apnea in terms of how low their oxygen goes during the night, as well as how many times they stop breathing at night.
Right.
So someone who snores doesn't necessarily have sleep apnea, but usually someone who has sleep apnea snores. So we see a lot of patients coming in for snoring evaluations, and we're evaluating them for sleep apnea. And why is it important? Actually, you can put up some slides if you'd like.
Yeah, that'd be great.
So let's put this here. Okay, is that coming through okay?
Yeah, it looks great.
All right. So so we said sleep apnea is kind of a pause in breathing with an associated drop in this oxygen saturation. In the United States, pretty common amongst the population, 10 to 15% of US females, and almost double the prevalence in US males. And what we said is, the severity of it. How bad is it? How many times do you stop breathing? How low does your oxygen go? And you can tell that on a sleep study. So you can either do that in a hospital setting, or now we're more commonly doing that at home, where you hook up a few monitors and then it's going to give us a number as to how bad is it. And that's called the hypopnea index, our apnea hypopnea index. And the number is kind of graded from normal to mild to moderate and severe. And that kind of can correlate with what are the risks of untreated sleep apnea. So aside from just feeling tired, what happens if you don't treat sleep apnea? And we have studies that show that untreated sleep apnea leads to higher rates of high blood pressure, heart attack, stroke, abnormal heart rhythms, decline in cognitive function. You can imagine if you're not sleeping well, you just can't think right.
Right.
Harder to control diabetes, depression, insomnia kind of interplays with sleep apnea. And so, we see a lot of kind of downstream medical problems that not always caused by untreated sleep apnea, but often make it harder to treat those conditions. So that's why we care about it. And that's why it's important, more so than just you feeling tired. There's medical benefit. And, we also worry about people, say, driving a car when they're tired and operating heavy machinery.
Absolutely.
And things like that.
Doctor, is there a correlation between the rising obesity rates in the nation and sleep apnea?
Absolutely. So there was a study that came out in the fall of last year called the Surmount OSA trial. And they were looking at, if you've seen in the news, there's these new medications called Wegovy and Ozempic that have come out. They're originally for diabetes, and we've seen a lot of improvement in people's weight as a kind of side corollary. And there was a medication that came out in the fall that worked in a similar way, that they actually studied people's sleep apnea numbers as it correlated to weight loss. They saw a significant reduction in people's AHI numbers, or sleep apnea severity, as their weight dropped as well. So we've always kind of known that it was a strong corollary, but this was a large study that really looked at weight loss and the impact on those numbers.
That's a great study. How interesting is that? Now you have everything to back that too. So how hard is it to go do the sleep studies? I've heard that you can do those at home. Is that something like...
Yeah, they're pretty easy. One of kind of the good things that came out of the COVID pandemic was how much easier it made sleep studies. It used to be pre-pandemic, we would order a sleep study for a patient, and insurance was kind of always asking us to do it in a sleep lab, which for some patients might be an issue with travel. Some people just don't sleep as well outside of their home environment. And so when the pandemic hit, we had switched to doing them at home for safety reasons. And now that has become kind of the standard, that most insurance plans ask us to do it at home first. And then if, there's any issues with the results or coordinating that, we can do it in the lab. So in general, they're very easy to get done.
So now someone has a feeling that they probably have sleep apnea. They go, they have this conversation with their primary. They get a referral from their primary?
Exactly. So I've seen it kind of go both ways, where some Some patients, their primary will work them up. But a lot of times they get sent to us. The primary care will be like, hey, you're snoring, or there's a concern for sleep apnea. Let's get you over to an ENT and have them kind of evaluate you and do the workup and kind of figure out, what the next steps are.
Now, suppose this is me. So I've done that. I have the referral. I'm walking into your office. Like, what do you do with me? Like, what are you looking at? And
yeah, so we're trying to tease out. Okay, are you snoring, or do you have signs and symptoms that are concerning for sleep apnea? And we can often get that just from talking to the patient about, what are your symptoms? What are your concerns? How do you feel in the morning? How do you feel during the day? Do you feel like you have to take a nap to get through your day? Would you fall asleep in a dark room or in a meeting at work? Sometimes things like headaches in the morning are a symptom of sleep apnea. So we have a set of questions where we can kind of tease that out for a patient. Part of what we do is we also want to do an exam and do an upper airway exam. And that involves kind of looking at your mouth, your throat, the size of your neck, the shape of your body. And also sometimes what we'll do is we'll look with a small camera in the nose to take a look at the nasal anatomy, take a look at your airway, your throat, your tonsils, and see is there points of obstruction that can be contributing not only to snoring, but airway collapse, where we think, hey, that might be what's causing your sleep apnea, because that's sleep apnea is.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. So today we'll be discussing women's cardiac health with Dr. Randy Averback. And before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. So, Dr. Averback, so good to have you here today. We really appreciate you coming along and talking about this really important topic. But before we get into that, why don't you tell the audience a little bit about your background, because I think that would be important for them to know.
Sure. I've been in medicine for 38 years now, practicing. And I was probably a little older going to medicine at the age of 27 anyway. But my first college was Rhode Island School of Design in Providence. And then I was in Toronto, where I couldn't work. I had gotten married, and they had a program in art as applied to medicine. Okay. So the portfolio that I had from RISD, I used to go into that program, but I had to sit with the first-year medical students and compete in order to get through the program.
Oh, geez.
So after the first year, I had asked them, can I finish the art as applied to medicine program, but then go on into medicine? And they offered me the position, and that's how I got there.
Oh, that's awesome.
That is so cool.
You didn't have to go back and do any other classes? You were able to just go forward into the program?
I needed to create the original application information that people would have created to apply for medical school. Right. So I did that in the summer before I went back into the second year class.
That's incredibly original.
Yeah, it's a little unusual.
It is. It is.
Yeah.
What was it about sitting in those classes that made you think that you wanted to go into medicine? Because it sounds like you hadn't really thought about it before.
No, I had no preparation to go into medicine before. Sitting in those medical school classes, they had some wonderful teachers. And it was particularly the anatomy class and the neuroanatomy class.
Okay.
I had a teacher that he was ambidextrous, so he would draw his diagrams for neuroanatomy with both hands at the same time.
That's amazing.
And he would say to us, don't worry, I'm going to teach you about this section and this section of the brain and this section, and about a week before the final exam, you'll understand the whole thing. And we did.
You did. That's great. Yeah, it's amazing how a good teacher can make such
Yeah.
a difference. So then you went through medical school and you ultimately decided to go into cardiology.
Yeah.
And what was it about cardiology that attracted you?
Cardiology is very challenging. It's not just a physiologic process, but it's a investigative process, thinking when dealing with people with all kinds of cardiovascular disease, you get to help people, to intervene. There are people who are walking around because of what's happened, over these years, because of things they've said or things they've been asked. There are obviously very many other subspecialties, but some of them move a little faster than others do.
Right. Right. And cardiology moves fast. Again.
Very fast.
Yeah.
Very fast. It's been, since I started practicing, some of the most basic drugs, ACE inhibitors, beta blockers, which did not exist
Right.
to any great degree when I started, neither did echocardiogram. All of that got developed. And during all that time, I had to retrain as each new thing came along with echoes, with CTAs, with implants for ambulatory monitors. All of those things had to be retrained.
Yeah, I'm really amazed at how cardiology has just, it's advanced so much more than other fields in medicine.
Yeah.
I mean, there are others that have advanced quite a bit too, but cardiology is striking.
Yeah, it is striking.
Right? The
Yeah.
technology is amazing. I mean, think about, aortic valve replacements with TAVRs now, which
Yep.
is basically, instead of opening someone's chest open, just to do it through a catheterization. It's remarkable.
It is
That's
remarkable.
changed the whole face of that procedure
Yeah.
for many people.
Absolutely. And given the fact that the valve that's used, that whole procedure, without having to open the chest, was used on the sickest of patients
Right.
to start with, those people that could not possibly have survived an open heart surgery,
That's another point I never thought about.
who did incredibly well. And then the use of the valve has gone to less sick people and then there's another whole set of criteria that's
Right.
come along with it.
Yeah, it's remarkable. So many new changes and
Yeah.
new developments.
Yeah.
What we wanted to really talk about today and focus on is women's health, women's cardiac health, because it's something that sometimes, I think there's more knowledge about it now, but I think it's something that we forget is so important with women. It's actually probably the number one cause of death, I would think, in women.
It is.
Right.
Absolutely. It's been that way all along. Through the years, actually through the decades, there has been more information about breast cancer,
Right.
ovarian cancer, uterine cancer, but by far heart disease is the number one cause of killer
Right.
of women.
Right. And it's obviously it's important that we have attention towards breast cancer and those other conditions, but for some reason, cardiac disease in women has never been recognized. It's more so now, but it hasn't been recognized as much as it should be. And that's why I thought it'd be really important to talk about that today.
I think it's very important to talk about it. There are some things that have changed. I mean, there are certain ways to deal with preventive measures.
Okay.
And then there are things about women that are different from those about men. Once a heart attack is present, once a stroke is present, the symptoms we should talk about a little bit, because I have
Sure.
a little bit of different feeling than perhaps the typical presentation
Okay.
of what women's symptoms are. And even more importantly is, how do you get someone, female or male, but female, to tell you what's actually going on?
Right. So,
And come in.
so where do you want to start? Do you want to start with how the presentation might be different, or?
Sure, we can do that.
Okay.
We can do that. If we refer to the community around here, because it is different in different communities. Some have, there's a kind of joke, in certain communities around Boston, there are people that have 3 doctors for the same issue.
Right.
Here, there is very significant disease.
Absolutely.
Coronary artery disease, heart attacks, valvular disease, heart failures, atrial fibrillation.
Right.
In the entire community, it's one of the most obvious, outstanding things when you come to practice here.
Absolutely. It's amazing.
Yeah. And so, and you're dealing with a community, and I don't speak Portuguese, so there has to be a translator. But usually what happens is that there's a family member. That always amazed me, particularly in the hospital. There would be not just a female there would be a grandson,
Right.
there would be an uncle, and someone would
Yes.
come to do this, to do the translation, that knew the person.
Yeah.
And I could, while I'm looking at the person, address them directly by simply asking them to repeat, and
Sure.
answer what I'm asking them, which does the best. That's the best way to get information.
Right.
Yeah, I think it's a culture that's defined by a very strong extended family.
Oh,
you know,
yeah.
a very strong nuclear and extended family.
Yeah.
Yeah.
I mean, I was amazed, I would say maybe 7 or 8 years into my practice here, when I was working as one of the primary care cardiologists on the cardiology floor in the hospital. And we knew that the patient there was going to pass away. There was a huge family gathering. The room was full. They were kind of standing out in the hallway, and they started to sing. And the tears are coming down my face, but they started to
Right.
sing. The person passed away.
That's wonderful. It is remarkable, though, how much heart disease is in this community. I remember when during my residency, I had a residency clinic like all of us did, and
Yeah.
I didn't see any heart disease at all. I saw some hypertension, but I didn't see coronary disease or heart failure, any of that. It was a very healthy community. Hardly saw any diabetes. And then I came here, and everyone was diabetic, and everyone had heart disease, and I was astounded. It was incredible, actually.
Yeah, and the better we do in taking care of it, the older everybody gets,
Right.
and the more it goes on, and the worse it gets with
Right.
it, and the better we
Oh
do,
my
and it's a circle.
Right. So how do women present differently with their heart disease? And I know that's a really broad question. We have coronary disease, heart failure, lots of different problems, but maybe you can talk to us a little bit about that.
If they come in, or their family brings them in, and we're speaking in English directly, they do have chest pain, they do have arm pain, they have nausea, they have fatigue, they have shortness of breath. But sometimes they tend to use words differently.
Okay.
So the choice of the word is different, and you get the feeling that people are trying to tell you exactly what's there, but the word chosen is different.
Okay.
I've never heard that before. That's such an interesting observation.
It's how the English language is used, and that's the opportunity when you're sitting opposite them to say, can you give me another word? Can you use a different word to describe this thing? Do you feel it here? Do you feel it here? Do you feel it up here? Is it pounding? No, it's not pounding. Are you breathing heavily?
Right.
does it occur in the same pattern, say, that angina would occur? Sometimes you realize that they're talking about pain.
Okay.
Or they'll say, oh, my heart is pounding. Well, their heart is pounding because there's adrenaline rush,
Right.
that's there. It's an adrenergic rush. And yeah, things are off. Either they're very hypertensive or they do have significant coronary disease, and it does need to be approached. But the sensation is described by a different word.
So in the Portuguese community, how would they describe, say, typical angina? Would it be described differently than what we usually hear, which is like pressure in the chest?
I rarely hear the word pressure.
Okay.
What do you hear most?
There's some feeling, or it's sharp, and my next question will be, show me where it is. And can you give me some more words to describe what it is you feel? Does it have other feelings? Does it work its way around the chest into different locations? Does it move? How
Okay.
long have you had it? And I think that in order to separate out what people are really describing, and if you're looking for angina there, that's a kind of presentation that usually occurs somewhere between your nose and your belly button. It's usually on the front surface.
Right.
Sometimes it's in the back between the shoulder blades
Right.
there, or sometimes maybe going up the neck, but I have not heard that commonly around here.
As far as pressure.
But
Yeah.
it's a feeling. It's the feeling that you've never had before.
Okay.
And you had no idea what it was when it started.
Okay.
And it went away. But the next day it came back. And it's in the same location. And then it starts to build. Maybe it's there twice that day.
Okay.
Okay.
All right? Maybe you've had to slow up because you're short of breath.
Okay.
People will say, I'm getting old. Now,
Right.
when I'm older than they are, and they tell me that they're getting old,
Right.
You're like, what?
So they may just describe it as I can't do as much as I used to.
I
I'm getting
can't
old.
do as much. This hurts, and that I just can't breathe. I'm very short of breath.
Right.
Doing this thing, and can ask them, what are you not doing that you could do 6 months or a year ago?
Okay.
Can you do?
That's a great way to look at
You
it.
have great investigative skills because you like to ask people a question different ways. Like I don't hear that often, and it's just really great that you do that because
That's where I get my information from.
yes.
And you have to have a lot of like cultural knowledge and
Awareness,
sensitivity and
yes.
awareness to be able to delve into this and get the answers that you're seeking.
Well, I think if you honestly, no matter who you have in the office, male, female, young, old, somebody out of a nursing home there with their family, once you make contact, once you're talking directly to the patient, eye to eye, and they acknowledge, if they can, you acknowledge, and you keep doing that, even though you're getting a translation
Right.
from a family member, you just keep going, you can push them a little further.
That's so important. Yeah.
When I was training, when I was at the Brigham, I did a fellowship in preventive cardiology
Yeah.
there through the Harvard School of Public Health. And one of the studies that I had worked on was to look at the data that was collected from people over 65 as to what they remembered about what happened, when it happened, what they did, what their symptoms were.
Okay.
And the significance of doing that was that they can't remember to a significant degree. They're not able to provide that data.
Right.
But if you push them in and suggest different words, or, can you make the bed? Who does your shopping? Who carries up the water that you're drinking
Exactly.
there? Who loads the
Exactly.
shelf,
Right. So it may come out that maybe they were doing this a year ago, but now they just
Exactly.
can't. Things of that nature.
Exactly.
Okay.
You were talking a little